Today, we are very honored to have Prof. Jamal I-Ching Sam, who is a professor in Department of Medical Microbiology. I'm Professor Chan Yuk Fan from Department of Medical Microbiology as well. So his topic is on updates of emerging respiratory viruses and also the technology. Over to you, Jamal.
Okay, thanks, Yoke. Hang on. Okay, hopefully everyone can see that. You see that?
Yes, it's good.
Okay. So thanks for the intro. Good morning to everybody. So today for my talk, I'm going to split this talk into two and give some brief updates about emerging respiratory viruses, including pandemic risks, and also to cover some new and old viruses and some UMHealth epidemiology. And then I'll also briefly touch on some of the advances in diagnostics, particularly what we're using here in the hospital. Okay, so just to start off with, the first pandemic I was involved in, I had to go to a WHO meeting in Beijing in 2009, and a very eminent CDC scientist said to me in a very excited way that this is a once-in-a-career event. So this is a well-known figure which shows the many emerging infections around the world in the last few decades. And what I've highlighted here in the green explosions are the respiratory viruses which have occurred, at least in terms of causing outbreaks or clusters in Malaysia, or we've had to prepare for. So these highlighted ones are what's happened just in my fairly brief career. Of course, not all of them have gone on to cause pandemics, but at least some of these have caused outbreaks, and of course the SARS-CoV-2 and H1N1. So it is probably not, well, for me, it's not a once-in-a-career event anymore, and it's unlikely that this will be a once-in-a-career event for most of us. So, of course, I have to mention SARS-CoV-2, no getting away from it. This is a figure which shows the variants which have been circulating in Malaysia for the last 3 years. And this is based on about 25,000 SARS-CoV-2 sequences, which have been deposited into GISAID, which is a public database. And you can see here, it kind of charts the history of waves that we've had, the Beta, Delta, and Omicron. What's happening at the moment is for the last year or year plus, we and the rest of the world have basically been experiencing continuous kind of waves of subvariants of Omicron. None of them have been declared as variants of concern. And the most recently circulating one, the JN1, has been declared a variant of interest. But so far, these variants of interest or those ranked lower do not seem to be causing any major increase in severity of symptoms or vaccine failures and so on. And this probably will continue to be the case for some time. But the viruses that I highlighted in the big map earlier come from 4 families: coronaviruses, adenoviruses, picornaviruses, and orthomyxoviruses. And it's worth mentioning coronaviruses because we've had at least 3 that I show here: SARS-CoV-1, SARS-CoV-2, and MERS coronaviruses, which have crossed over and cause problems in humans. So this is a phylogenetic tree, which basically is like a family tree that shows genetic relatedness between different viruses. And what this shows is that the 3 human coronaviruses that I mentioned earlier are also very closely linked to viruses which are found in bats. So you can see, I'm sure you can see my cursor, but there's a lot of bat virus sequences here. Related to SARS-CoV-1 and some related to SARS-CoV-2. So bats are the second largest, most diverse order of mammals apart from rodents. So there are many thousands of species of bats, and there are many thousands, if not more, viruses which infect these bats, of which we know nothing or next to nothing. So really one of the dangers in the future will almost certainly be coronaviruses from other species. Another important thing in humans is influenza caused by avian and swine influenza. And these always carry the risk of mutations so that they become more adapted to humans, able to spread and cause disease in humans. So you've certainly heard of avian H5N1, but there's a whole list of subtypes which cause avian, which are avian influenza subtypes, which have been reported in humans before, and also some subtypes which are found in swine and which are differentiated from human ones with a little v for variant. And as you can see from this figure on the right here, there's basically risk of these viruses passing between the mammals. So H5N1, of course, first appeared in 1997 and is the most well-known. But there's been particular concern for the last year, a couple of years, because one particular clade or particular sublineage called the 2344B lineage has spread in a very unprecedented way. It's been reported in over 80 countries, has caused deaths or at least required culling of over 150 million domestic birds. There have been reports of wild bird mass die-offs. But what's more worrying is that in over 13, well, more than 13 countries now, this particular virus strain has been found in up to 29 species of mammals, including farmed minks, even things like seals and domestic pets, cats and dogs. Only 12 human cases so far, but what is worrying is that if this virus shows the ability to jump species so easily to other mammals, which this particular clade is done in an unprecedented way, then there's a concern that adaptation to humans is not far off. Okay, so this is something that we need to be concerned about. There's also been a lot of new viruses, which are, or at least viruses which are newly associated with respiratory tract infections. I'll just comment on a few which have been reported in Malaysia. So the bat orthoreoviruses, there's a report which showed that terrapin orthoreoviruses may be detected in up to 2% of outpatients with respiratory infection in Malaysia. A few years ago, there was a novel canine feline recombinant coronavirus, which was identified from a pneumonia patient in East Malaysia. We've had outbreaks of enterovirus 68 in Malaysia, causing respiratory infection. And we've also detected Suffolk virus, which is, again, a recently associated virus with respiratory infections. So there's a whole bunch of other viruses out there which we know very little about, and we're certainly not looking for, which potentially may cause respiratory infections. And we don't know what their pandemic potential is. Of course, there's also been old viruses. So quite recent, well, not recent anymore, but in 2011 to 2014, there were outbreaks of adenovirus type 7, which caused a big outbreak in a police training center and affected 100 plus people. And then in a short couple of years duration during that time, pediatric department also noticed quite a lot of adenovirus admissions associated with severe disease, bronchiolitis obliterans as a complication. And a lot of these were associated with type 7. So some of these older viruses can reappear. Older viruses, epidemiology can also be changed quite severely by pandemics. And a good example is during SARS-CoV-2 pandemic. So this is in this figure shows the number of cases diagnosed in UMHealth before the pandemic in 2020. And the green lines are the SARS-CoV-2 cases. And you can see that we had RSV and orange and influenza in blue before the pandemic, but they basically just disappeared during lockdown. And then when lockdown was lifted, there were surges, particularly in RSV. And in some countries, like in Australia, these RSV surges were unseasonal. In other words, they didn't occur when they normally were expected to occur. And they were also associated with increase in hospitalizations. Okay, so briefly about molecular technologies. I think since pandemic, we've all become very experienced, and molecular technologies have become much more easily accessible and cheaper. And it's actually not that long ago, 2008, when the first multiplex PCR panel for respiratory viruses was approved in the US by the FDA. And it was only in 2015 that the first molecular point of care test was introduced, and these are shorter. They can be done in outpatients or in kind of like in emergency departments. In other words, they can be done outside of laboratories, and they don't, despite being quite complex technology, they don't require fully trained laboratory staff to carry out. And then in 2020, the first CRISPR-Cas technology test was given emergency approval for SARS-CoV-2. And this is also a rapid, fairly easy to perform test, which doesn't require major equipment and laboratory resources, and can be done in a short time. So perhaps more of this will be seen in the future. So we've introduced multiplex respiratory PCRs for the last couple of years, and we've certainly seen a very large uptake of this syndromic test now, with a fall in SARS-CoV-2 PCR, because now we're looking at respiratory syndromes rather than specific pathogens. And this is the panel that is detected by the current assay that we use. And just a few things to point out here, that it can give you a lot of information, which is not just flu B positive or RSV positive. So I'll just give you a few quick examples. In this assay, there are 4 PCRs for influenza A. There's a influenza A which detects all influenza A, and then there's 3 typing assays which pick up pandemic H1N1, so-called seasonal H1N1, or H3. So if, for example, you get a good positive for flu A, but the typing PCRs are negative, this is worth looking at further, because these are the main circulating human influenzas. And in the right epidemiological context, if you get this kind of picture, you might want to suspect avian influenza and require further typing for H5, H7, and so on, which are not picked up or not distinguished in this assay, but the influenza A general PCR will pick up. So similarly for SARS-CoV-2, in this particular assay, it uses 2 genes to detect SARS-CoV-2. There's a specific SARS-CoV-2 gene called RDRP, but there's also a gene which is a little bit more general and can also pick up SARS-CoV-1 and other bat coronaviruses. So again, if you pick up something like a E gene strong positive with a low CT value, remember a low CT value means a stronger positive, but a negative SARS-CoV-2 specific gene, then you might want to think about, is there something else going on, some other unusual coronavirus or SARS-CoV-1, which has not been seen since 2003. And then, of course, we also pick up adenovirus and rhinovirus, enterovirus. And if there's ever we notice a spike of these things or clusters or outbreaks, these can be further typed if necessary. So this particular message, keep the positive samples, is more aimed at other laboratories, but it's an important thing to know that this kit or these results can give you a lot more than just a simple yes and no. They can also indicate need for further investigation, and if you keep those samples, that can be done. So we keep all our positive samples. Okay, so I'll just give you a little brief thing about the epidemiology. So one of the benefits of having this multiplex PCR and UMMC is that you get really a lot of detailed surveillance data of viruses which are much more sensitive and specific detection than the previous IF in culture. So this is the main viruses detected in the last year, 2023, and this represents percentage positive of the overall samples detected. And you can see that over the year, you have different viruses becoming predominant at different parts of the year. So, for example, at the beginning of the year, we had a lot of RSV, and then in around April, May, and the end of last year, we had spikes of SARS-CoV-2, and then in the last sort of 3 months of the year, we also saw quite a lot of influenza and enterovirus and rhinovirus. So this kind of surveillance data is quite useful to know, particularly if you're thinking about treatments, for example, for influenza. Just breaking down this data in a little bit more detail. So when I split it by age group, so this is the most common, these are the most common virus detections in under 12s. And you can see mainly rhinovirus, enterovirus, and RSV. I should perhaps have broken it down to younger age groups where you would expect to see RSV much higher. In adults, you get more influenza, influenza being the most common, and also SARS-CoV-2 compared to children. And what's also worth noting is that in the elderly, greater than 60 years, a pretty good proportion of them are also getting RSV. And this is important because the FDA has recently approved RSV vaccine for the elderly, and it might be something that might be considered here as well, as RSV seems to be causing disease in elderly, which we never really looked for in the past when we didn't have multiplex PCR. So other things of note, if you look at the number of, if you look at each age group in a little bit more detail, you can see that the younger age groups have a higher positive rate of 80%, whereas this gets lower as you get older and drops to 40% in the elderly. And this is consistent with the fact that children are always getting one viral infection after the other, so that you often pick up RNA or DNA of recent infections, which the child may have had a few weeks previously, which is still positive. And this is reflected in the fact that the average positive detections per positive sample are higher in children, so 1.3. So you're more likely, as the pediatricians know, to get multiple positives in PCR, where it can be sometimes a little challenging to determine which one is causing the current problem. And then just to finish off with a brief mention about next generation sequencing. This allows high throughput, fast scalable sequencing of very large genomes or genes. And this can be done with increasing cheapness and accessibility. So the main use of it in medical microbiology is to do whole genome sequencing of a pathogen, which we, of course, were part of for looking at the epidemiology and evolution of SARS-CoV-2. But it can be also used for outbreak investigation, which we have done in the past for SARS-CoV-2 outbreaks in the hospital. You can look it up in the cited journal there, cited article. Whole genome sequencing can be used to screen for drug, vaccine, and diagnostic targets and pathogens, and also, therefore, to understand resistance, and also can look for virulence determinants and so on. You can also use NGS for metagenomics, which means that you can test the sample for all the organisms present, including known colonizers, plus also unknown, novel, or undiagnosed pathogens, which may not be detected in the normal panels that you use. So we've kind of done this in the past, where we took samples which were SARS-CoV-2 negative, and we did metagenomics, and we found patients who had enterovirus D68 and saphovirus, which were which were not previously diagnosed. And the patient with saphovirus, in fact, was in ICU with pneumonia. You can also use NGS, of course, for human gene expression transcriptomes. For example, if you wanted to distinguish between immune responses in viral or bacterial infection. Okay, so in conclusion, there is continued risk from many potential emerging respiratory viruses. Most of these are RNA viruses which originate from animals. So molecular tests are trying to keep up with this kind of constant and evolving threats. So it's worth knowing or trying to understand a bit better about the limitations and the potential information that molecular tests which are available to you as a practitioner. Try and understand them a bit more, speak to microbiologists to help understand them. And perhaps in the future, with greater cost reduction and accessibility, NGS may become a little bit more routine. So with that, I would like to acknowledge the Diagnostic Department of Microbiology in UMHealth, who worked very hard during the pandemic and continue to work very hard every day. A research lab and some of the funders for some of the respiratory work that has been done in my lab. Thank you.
Thank you, Prof. Jamal. Is there any question from the floor? Okay, I saw a question. Okay, there's one question here. What is the PCR multiplex CT value number suggests of an O infection?
Okay, so that's a good question. I think a lot of people face that with SARS-CoV-2. There's no cutoff, of course, because we don't really know, and also it also depends on how well the sample is taken. So if you take a really good sample, then you may detect more virus than if you don't take a very good sample. So the cutoff itself is not that helpful. But generally, the lower it is, the better. I mean, sorry, not better, the more likely it is to be a more acute kind of infection. So this is kind of related to Naeem's question, is there any co-infections? The answer, of course, is yes. As I've shown earlier, we've had quite a few positive detections with more than one per positive detection. So if you get one of these samples where you have 2 or 3 positives, generally speaking, if you see one with much lower CT than everything else, like say 20 or 25 or something lower, whereas everything else is 35 plus, so that the cutoff is about 40, depends on the assay, but generally about 40. So if you see one which is about 20 and 2 of the detections which are 35, 36, then it is likely that the lowest CT value one is the causative agent in this case. Also, some of the viruses are more likely to be asymptomatic. So the key ones that are highlighted there, RSV, flu, adeno, and things like that, those, when they're positive, tend to be significant clinically, whereas the others, like the other coronaviruses like OC43 and Boca virus and things like that, they tend to be more likely to be asymptomatic, or if you were to test normal people, people with healthy and no symptoms, they will also have Boca and OC43 and so on.
Okay, another question from Mohan. Why the panel focus on H1 and H3 influenza A virus at most? How would it benefit the clinical management? Okay,
perhaps Dr. Mohan can answer that as he's studying for empath. So H1 and H3 are the main human, well, since the 50s and 60s, when we had H2N2 pandemic, H1 and H3 are the main ones, or in fact, practically the only ones circulating is human influenza viruses. So from the point of view of treatment, it doesn't really matter whether it's H1 or H3, the treatment and the infection control is the same. But the main use of it is more for epidemiological purposes. So because it affects understanding of the seasonal vaccine. Plus, of course, the usefulness of it is knowing if something is not H1 and H3, because that may give you a hint that there's some avian flu or something. I mean, avian flu in humans hasn't happened in Malaysia yet, but at least it's a way of keeping a lookout. Sorry, I say it hasn't happened. We had one imported case of H7N9 from a Chinese tourist some years ago, but not actually acquired in Malaysia. So at least now we have, in the past we used to just say it's influenza A, but now we can at least survey whether these are possibly something apart from the usual H1, H3. Thanks for the question.
Okay. We have 3 more questions in 3 minutes.
Oh, do we have time? Okay, right.
Okay. Prof. Sakunan asked, how do we assess the influence of climatic change on emerging and old virus?
How do we assess the effect of climatic change? Well, Sagunan.
We have done a paper.
I think, yeah, I think climate, we have done something like that, but there's a lot of factors which can potentially confound the effects of climate. People have looked at it. It is possible. I think if you have very large national data and very specific different weather data, and of course there are many other things which are difficult to measure, like population immunity and patient demographics, like younger children are more likely to get RSV and so on. So I'm not aware that there's a clear correlation between weather or specific types of climate measures with respiratory disease.
I think mainly in temperate countries, the seasonality is clearer, not so much in...
Yeah, sure. Sorry, yes. Apart from winter and stuff, but I guess what Sargon is looking at is perhaps
our last change.
Yeah. Okay.
Do you have any explanation for RSV cases that went down dramatically during COVID-19 pandemic?
Yeah, that's an interesting question. So, of course, a lot of it is behavioral. That all the main sources of spread, like schools, nurseries, and so on, were all shut down, and everybody wasn't mixing. That was probably one of the main reasons. Well, in fact, probably was the reason. But then when things opened up, we had a lot of kids, babies, and newborns who had no immunity because they hadn't previously been exposed in the last year or so, and that's why there was an unseasonal bounce in many countries.
Okay, maybe I'll end with this one last question. So, if money is not an issue, what would be your plan to introduce what technologies in diagnostic lab in UMMC?
If money is not the issue,
what would you want? What's your dreamed technologies?
I'm okay with what we have now, the respiratory panel PCR, and I think we're lucky that UMMC has supported this. So, as I said, the demand for the multiplex PCR has gone up, so we're doing a lot every day now. But the SARS-CoV-2 and the IF culture have gone down accordingly. So we've basically switched to this, and I think everybody has found that very useful. It's quick result after an hour. So I'd like to carry that on and perhaps expand it a bit more if we had the money to do it a little bit more. Sometimes we're still restricted by funding. I think things like NGS are somewhat in the future, but can be kept for maybe instances where you really have someone ill in pneumonia and all your PCRs are negative. I think that would be useful to have in the kind of as reserve.
Okay, with that, I thank Prof. Jamal for his talk. I pass the time to Prof. Adina. Thank you.
Thank you. Have a good day.
Thank you.